This has gotten into also many of the guidelines that we use, and certainly in the adult world we rely on the NCCN guidelines. I don't know if Jay, if you could comment a little bit about the NCCN guidelines, and is there anybody, let me ask it this way, is there anybody who you think shouldn't have MRD testing when you're seeing patients?
Yeah. I mean, I think all ALL patients should be tested for MRD, so I think we should definitely be thinking about them. We should be not only thinking about them, actually doing the test to get the result, because it has a direct implication for therapy for a good number of these patients, and again, kind of making a decision about whether it's transplant or another therapy as well. So it's a little bit challenging to building the guidelines in adult ALL treatment of the optimal timing, mainly because we don't have a one standard regimen that everybody agrees on to say, and then at the end of this cycle, that cycle, that cycle. So with the caveat there, the general timing that we do testing for MRD is after induction one, which is usually kind of the 4-week time point, whatever the regimen they use, whether it's hyper-CVAD 1A versus kind of the pediatric or pediatric-inspired regimen for some of the other the regimens. So I think that's kind of the clear time point to get them. Although you can argue that based on that 4-week MRD, that we don't really necessarily make the treatment change decisions at the time, but it kind of identify our higher risk patients. Those MRD we do kind of follow after induction 2 or consolidation, or depending on which regimen again, which end up being about 3 months mark for most of the patients, whether it's again induction 2 or consolidation or another cycles of hyper-CVAD. So I think those are more important markers to say that can potentially make a decision, the treatment decision making. So in the NCCN guidelines, we kind of loosely use the term of induction, after kind of initial consolidation. But some of these regimens have a long consolidation, so we usually, I personally check them every time I do a bone marrow biopsy, the bone marrow aspiration to them, and there are a couple of different ways to do the MRD, and I will talk a little bit more about them, flow or the PCR. But not every institution, not every place may have kind of the optimal way to do them, but there are certain times it's kind of important to do. But throughout the consolidation, that we kind of make recommendations, again, depending on the regimens, which end up being every 2 or 3 months while you're on regimen, and then the maintenance therapy as well during the maintenance. I think the maintenance part, I think we also kind of let it a little bit loose in terms of the recommendation, because the bone marrow frequency, bone marrow aspiration assessment frequency during the maintenance for adult oncology is not well. There's no one regimen, so certain protocols every 3 months for the first year, every 6 months for the second year, but it's all depends. So I think, but the point is that I think the one thing that we wanted to emphasize is that just, this non-induction one consolidation, that you stop monitoring them. If they're MRD positive, again, you change the management. If you're MRD negative, you want to follow that MRD level to make sure that the wards are staying negative to again, you do optimize the management based on the level.
Yeah, it does seem to me that at least in the adult world, it's not etched in stone when we do these measurements, and I think it is somewhat regimen dependent. Can you give us a pediatric perspective, Rachel? I think maybe you have a little bit better defined, since your regimens are a little more uniform.
Right, and they aren't completely uniform, certainly, but I think everyone has a pretty defined induction that's 4 to 5 weeks long, and I think that MRD time point is proven most prognostic. That's, however, would be confined. I think this is lineage dependent as well, because I think B-ALL, that early time point, is highly prognostic, but T-ALL we know can take a little bit longer to clear and doesn't seem to have the same impact on outcome, and therefore really that second time point for the T-ALL patients seemed to be most critical in terms of clearance and correlation with outcome.
When is that second time?
So that's after, at least in the Children's Oncology Group, that's after consolidation, so that's another 2 months of therapy after induction. That does vary from consortium to consortium, but that seems to be more prognostic for our T-ALL patients in particular. I think there's some really interesting data about time to clearance and also level of MRD that's prognostic based on genotype. The UCal published a wonderful paper early last year where they showed that not all MRD is created equal. They looked at not only what your MRD level was just at a flat cutoff, but as on a gradient, and they found that actually the patients with favorable cytogenetics tended to do well, even if their MRD was slightly higher at end of induction. We looked at our COG data and found that patients, we have 2 favorable cytogenetic subsets that we consider: the ETB6-RUNX1 fusion patients and patients with hyperdiploidy. Specifically, we use double trisomies of chromosomes 4 and 10 in the Children's Oncology Group. it was really interesting. We found that patients who had double trisomies of chromosomes 4 and 10 did fine if their MRD was between that 0.1 and 0.01%, with just standard non-intensified post-induction therapy. Conversely, when we looked at our ETV6 RUNX1 patients, they didn't do well unless you intensified their post-induction therapy in that same range. So for us, our genotype-specific threshold is for the double trisomy patients in particular. So I think there are, I think it's very clean to apply the same threshold to every patient, but that may not be necessarily the case for all.
What do you do actually for LBL patients? I think that's probably the one setting the MRD testing is not very straightforward. Patients who don't have any bone marrow involvement and just kind of more lymphoma disease and just mediastinal mass and don't find anything. I mean, there's really no good tool for. I think to your question about is there patients that wouldn't be testing for MRD, for patients who never really had a blood or the bone marrow involvement, those are we do PET scan assessment, which is far from being MRD level by any means, but. How do you, I don't know the children's oncology group, but the LBL, is there any risk stratifications and kind of because you can't do
right,
MRD
and
assessment
it's a relatively rare population, so it's been hard to do the same kind of powered studies that we've done for lymphoblastic leukemia patients. We are studying the impact of minimal marrow disease at diagnosis in our B lymphoblastic lymphoma patients on our most recent trial. So I think we have a lot to learn in terms of how to stratify them. We don't even know about cytogenetic features or anything. So I think we have a lot to learn, and I would be interested in hearing your experience.
Yeah, we don't. I will sometimes include PET scans, but I think it's a pretty healthy extrapolation from the Hodgkin lymphoma and DLBCL literature to assume it has to be PET negative at such and such a time. Even things like Deauville scores and things, we don't really know if any of those tools apply to lymphoblastic lymphoma. So I think you're spot on, Jay. It's a challenging population to apply a risk-directed therapy and response assessments. In my experience, fortunately, those patients tend to do pretty well. So I'm usually, transplant's usually not something I'm thinking about for most of those folks, but they're definitely a subset that don't do well, and unfortunately, it's hard to know who those are.
Well, I think, Rachel, I think you made a nice point that we kind of tend to think, again, in a little bit simplistic way that all MRD is the same, and it can vary by the time point with some of these other factors that you weigh in. I mean, our goal is to get people to MRD negative, but I've always wondered, is a patient that becomes MRD negative after initial induction the same as the one who's MRD positive, and then you give blinatumomab, and now they're MRD negative? You tend to think that's not the same beast, and that patient likely isn't going to do as well. You're happy they're MRD negative, but you're not as sure that has the same significance.
Yeah, Mike Borowitz published a paper a few years ago where they showed that intensification of post-induction therapy, led to earlier clearance of MRD. However, it's a very interesting survival curve to look at, because while they're separated for a bit, they end up overlapping again. Therefore, it seems to just delay those events. Yeah. So blinatumomab may be quite different because that was just standard intensification of chemotherapy. So I think it'd be interesting to see, now that we're more and more incorporating blinatumomab into upfront therapy for patients, what that really does not only to your MRD clearance but ultimately to your disease-free survival.